Yeah, good morning, everybody. Can we show the slides?
It's working, eh? It's working?
Yeah, we see the slides.
Yes. Okay, this is the case one, 85-year-old male who actually presented with shortness of breath, walking, only just 2 blocks with the past medical history as we've shown, significant past medical history. Most important is
Sorry, they've been like bouncing. No, so it's fine. It's fine. Fine.
lymphoma and radiation therapy. That probably is the most important. And then if you see he has echo, we will show shortly that he had normal EF with severe mitral regurgitation with flail P2. Medication has shown there, and EKG he had sinus bradycardia with first degree AV block and right bundle. We hear some talk from Liraka. So this is the TE which you are seeing, at least moderate to severe mitral regurgitation. You can see the flail leaflets. We'll show the live shortly. This is a 3D color with a nice flail and the mitral regurgitation. So this is what we have got, the distance as well as the leaflet length, anterior as well as the posterior. So the MPR is showing the valve area about 6.1, a large valve. So here we are, a patient with the symptomatic mitral regurgitation, degeneration with flail P2. Plan is to do hopefully just a single clip. So
so let's have Lucy show us live echo images or the baseline echo images.
Hi, good morning. Yes, so this is live now. So you can see overall EF has remained unchanged, nice and normal, both on the LV and the RV side. We still have that flail leaflet. It's really well seen here with the ruptured chordae and that eccentric severe mitral regurgitation seen here. When we localize it, it's just lateral to A2P2, and you can see the leaflets here. Leaflet lengths measured about the same as baseline, and on 3D, you can see the area of the ruptured chordae with flail here. And that is where the primary jet of regurgitation originates from. Our vena contracta area was 0.43. We were unable to do a PISA due to the eccentricity of the jet, and the valve area remained elevated at a greater than 6. The patient is an AFib with an average mitral gradient of 1 to 2. Leaflet lengths posterior 14, anterior 27 millimeters at the area of where we're going to clip. And the septum looks okay. We did a 3D estimated septal height here, which a good septal height was at least 4.9 centimeters. And there was flow reversal in the right lower vein. You can see here us tenting. And prior to our transeptal puncture, we got similar heights as estimated on 3D. And I'll quickly show you our transeptal puncture here in the superior posterior portion of our septum with the needle across in a safe position, and then ultimately our guide here.
Okay, great, thank you. Let's ask Anita and the panel, any thoughts about this case? Would this clipping strategy be reasonable for you, or would you use another alternative tier device?
Thanks, Gilbert. I mean, it looks like a really interesting case. It's a degenerative disease. It's a long leaflet, so I think you have a lot of options. The flail segment looks relatively focal, so it certainly does look like it's a one-clip strategy. I don't have any experience with Pascal, but it looks like a great case for an XDW. I don't know what the other panel members think.
Yeah, I would say the same. I mean, I think anatomically, it looks like a great case for TIER. We use both Pascal and MitraClip, and I think either one would be great. Lucy, beautiful TE images, a lot of great information on leaflet lengths, on mitral valve area, and a really nice transeptal to start.
Yeah, we'll show you some fluoro images as well, actually, with some challenges associated with access. So you can see this is our initial transeptal. We use the Baylis system. We don't use VersaCross here. And then you can see that this is the sheath, the SL sheath, and you can see the Y going into the left superior pulmonary vein. we try to do that rather than going to the appendage. So just for the audience, you can see that was initially the appendage. Now you can see a superior pulmonary vein in the AP window. Now here this is a new one where the kink at the pelvic brim. Well, this patient had quite a tortuous, and now you can see the scoliosis there. And so we actually use it under fluoro to track to make sure that we can get the guide up securely. So, all right. So now Dr. Keeney is going to advance the clip. Let's look at floor
Can
echo.
you also show the hemo
Yeah, let's show the
V-wave
hemodynamics. That's a good point.
by the side?
So you can see the V wave and the mean atrial pressure here. Yeah, one moment. Can we show the hemo screen, please? Yes, perfect.
No, put it
Yeah.
on the fluoro. Small window on the fluoro.
Yeah, can you do a picture-in-picture with
Yeah,
the fluoro?
yes,
Yeah,
yeah,
perfect.
good.
Yeah, because we need
That's
to see
what we
echo
need.
as well. So, okay, so you can see that the mean pressure is on 28 and the V wave is on 45. Okay, so,
Okay, let's go.
all right, so what we're going to do now, you can see that I'm retracting the stabilizer while she's advancing the clip towards the pulmonary vein. There's a big atrium. And Lucy, of course, is showing us the clip position, so we're straddled already.
It's straddled and.
So, of course, we
nice.
try to make sure you don't hit the Coumadin ridge. So we go AM knob and then posterior guide torque. So we kind of know ahead of time. I know people, we work pretty quickly here based on at least our experience to be able to get down to the valve quickly. And then Lucy just show us the bicommissural view. And you can see that she's already reconstruct that for us. And we're going to go MPR, and you can see the clip's a bit posterior. So we're going to bring it back to the center of the valve. And then in the meantime, what I usually do is to do what I call jiggle to get the tension off the system. And because we're in an RAO projection already, we can kind of at least preliminary take the parallax out so that we can kind of roughly align with the clip orientation. So let's ask Lucy, where are we in terms of the clip position, lateral, medial? Let's just show the panel in the audience.
Yep. So you are.
So clearly, we need to we're looking for the flail. So we're a little bit more medial, looks like. So we're going to, yeah, so while Dr. Keeney is getting ready, we're going to advance the.
No,
No, you don't need to.
Mm.
So, okay, so there's the flail. Do people appreciate that?
Yes.
We have to go a little bit more lateral because you saw earlier is a lateral lateral A1P1. So we're just trying to fine tune our position here. The other thing we do is we minimize our respiratory tidal volume. So tidal volume is about usually 50, and we increase the rate again to minimize the respiratory variation. How does it look, Lucy?
You look okay. You're a little anterior. That's why I can't get you in a good bicom.
Okay, so you want to do we'll just check grippers now.
Okay.
So we raise the grippers, unlock, and then we're going to open. So you can see we already, just by using fluoro, got the clip pretty reasonable orientation. So we're going to check the grippers now, unlatch, drop the tactile. So you can see everyone agrees anterior, TA, and then non-tactile is posterior, TP.
Okay, let me get
So
it.
at this point, we'll go, you want to do MPR?
Yep.
Okay.
Just get it
So the advantage of MPR, we don't usually do it, but for the live case today, we'll show it because now with this new software from Philips, you can actually have a red line exactly imposed on the 3D on false image that allows you to see and determine the clip orientation. So it's actually quite nice. We just try it now as a test run. And so let's see if we can reproduce that. So obviously right now, the clip is not at the correct orientation. So what MPL does is that it's going to help us determine that, whether, where it's going to be. So I can already tell a little bit that we are two counterclocks. So I already just clocked a little bit so that preemptively we can, I think the next generation Philips software hopefully is going to allow this to be more automated. What you're seeing now, I think that's right now the biggest rate limiting step with MPR is that you have to do your 3D reconstruction, in real time manually. But my understanding is that they're going to come up with the next generation is going to be more AI driven and be able to actually do this more semi-automatically. That you click on the device or the pathology, and then actually automatically the MPR will get reconstructed. So how does it look in terms of the overall images?
Looks good.
And the orientation.
you want to counterclock a little bit?
Yeah, it looks like there's a little bit of medial dive, right, on the MPR. So we undo a little bit of M.
Sure, it's good.
What do the panelists and Anita, what do you guys think?
Your orientation looks good. I don't know, Sushil or Greg, what are your thoughts?
No, I think it looks good, and I think we use a lot of MPR. I think it's valuable for trajectory. I mean, the key thing is, we always talk about you need to restore the coaptation plane, and it's all about trajectory. And here you see, MPR, you can nicely line up to the annulus and get trajectory. And I think, Gilbert, your point, we've been in that Pulsar trial with Philips and Pascal, and it uses AI, and it will automate a lot of this, and sort of, especially as it comes to the tricuspid, I think advances in imaging are what's changing this procedure. I mean, MitraClip is different now than it was 10 years ago. And it's things like this that are going to improve outcomes, I think.
Gilbert, do you guys check color here for the position?
Sure, we can show you color. Absolutely. It's hard because I
Right
think
on
the
it
clip
here.
is blocking the eccentric jet, but you see it's, coming from anteriorly directed, right? You see that
You can see
on
it here.
on the red box.
The green.
So you're absolutely right. You want to see whether it corresponds to the jet as well. Although if it's a broad jet, it might be harder. So Lucy, you ready to go in the ventricle?
You're ready.
Okay, so we're going to close the clip. And you can see on fluoro as well, we like to take the parallax out. We like to cine it as a reference point. We teach our fellows the same way so that when you go in, you want to make sure it hasn't spun or rotated. And also, he has not done a medial lateral dive. So if everyone agree, I think we'll go into the ventricle now. So Dr. Keeney is going to go in, and then keep in mind, as I mentioned before, make sure it hasn't done any diving. So when you go in, you go very slowly. You maintain the trajectory. You can see it's pretty straight. It's a little bit posterior, so she's going to go a little anterior guide torque, just a little bit, just to get away from the posterior and not getting caught. And you can see we're under the
Can we
ventricle
come
now.
off MPR?
And then you can, let me flow save this. This is good. Okay, all right, so we're going to open.
Can we come off
Yeah.
MPR?
So
You see.
let's try this 2D for
2D
now and see
plus-
how it looks. Okay, so let's see how the 2D image. We usually just do 2D for grasping because resolution. So I think we're good. You can see the flail there. So she's going to come up and start. We'll go a little more posterior so that we can appreciate it. Good. So you can see anterior is on, posterior is on. We'll go a little bit more, and then I'm going to drop the grippers. So I drop very slowly for two reasons. One, you want to see the grippers dropping down. And also, two, you want to have enough time for the imager to be able to actually capture that. So I think we got a good anterior, but I think we might want to optimize the posterior. What do the panels think?
Yeah, I agree.
Anterior is in?
Yeah.
Anterior is perfect,
I don't think.
but not the posterior.
Okay, let's posterior.
Yeah, posterior I would do a little bit more, right? Because of remember Lucy measured the baseline measurements around 1.3, but we like to grab as much as possible. Lucy, what do you think?
I think it's good. Let's optimize posterior.
Can you speak up? I can't hear
Can
you.
we optimize posterior?
Posterior, good. Okay, so what Dr. Keeney is going to do, and I'm going to do on fluoro, I'm going to close the clip a little bit, and she's going to go posterior guide torque, and then she's going to go in because you don't want to go above the annular plane, and then she'll make sure on fluoro that your clip has not rotated. So you can see now, if you can show us that you can see now our grass is almost at the level of the annulus. So what we have to do when you do posterior guide torque, to be very careful about clip malrotation. So Lucy's going to show us the posterior clip arm before I bring up the posterior arm, right? So posterior gripper is non-tactile. So you can see we have pretty much everything in there. Okay, so I'm going to drop again. And I think this is pretty good there. So I'm going to lock. I like to lock early.
Are you
And
happy
then
with
we
the
go to-
anterior?
Close, yeah.
I'm sorry?
Are you happy with the anterior
We
graph?
haven't let go, so you can certainly, we can reposition that if you want to go a little bit anterior to do it, but I don't think we need to.
No, we're good.
Yeah, I think I would just
Close it.
close and see. So let's, but that's a good point. So she's going to, I'm going to start closing, making sure we haven't twisted the valve. Can you show the image, stabilize the image, please?
Rob?
Okay, we'll wait for Lucy to recalibrate. So this is a new upgrade for the Philips machine. So unfortunately, there were some of the settings that had to be redone because of the software upgrade. So that's why you're not seeing pristine images here. So we had that experience earlier in the week, but at least we're not doing tricuspid. So now we are actually going to start closing.
Yeah.
Okay.
Keep close.
So you can see that here. We give back tension. We're now below the annulus, and then I'm just going to close it tight.
We see
Okay,
a good,
so let's
good
see.
reduction of the V waves already.
Flow safe. Okay. So the V wave went from 45 now to 30. So let's look at the leaflet insertion first,
Leaflet insertion looks good.
First, put the color on.
View.
and look at some color. I guess everyone loves to see color.
Yeah.
Colors.
That's encouraging.
And okay, now check for the leaflet.
Any comments from the panel?
Everybody happy? Any concerns?
Yeah, Steve, Sushil, Manuka,
Yeah, I think-
Anita, you guys all
I
tier
think, it
experts.
looks, I think it
So
looks pretty good.
I mean,
Yeah.
the main part is, like, as you said, just to go explain and go across the clip. You want to make sure you capture the pathology in a flail. If
That's
it's a
right.
pretty narrow flail, but sometimes if you have a little bit of the flail out, I worry and I want to reposition. So if you just sort of explain on the
Good
commissural
point.
view left to right and make
that's
sure
right
that
for the audience. So
no
Lucy,
flail.
let's redo the bicommissural view.
You want bicom?
Make sure you stand up the we'll stand up the apex to make it really, and then you have to do correct. Then you have to do a sweep. So what we like to do, we do a lateral to medial sweep or vice versa, just so that, like you said, we didn't miss the pathology, right? So we can start from the lateral commissure maybe for the audience. And that looks good. And then we go slowly sweep across the valve. That's a little bit of lift there. We don't like lifts, but I think we got a lot already. Okay, keep going on the medial side. Okay, there's no flail there that we appreciate.
Flail.
Yeah, okay.
Yeah, but your
Think it's
point
good.
that
Do you
it's
want
still
3D?
prolapsing a little bit, especially on the medial side, and maybe there's still a
Right.
residual
So the
jet.
question is, should we try to grab more? Right. So that's the
Right.
question.
The posterior leaflet did have prolapse, but we
Yeah.
got the flail segment. So
Show 3D.
Yeah. Let's show a 3D and would anyone? Let's get a vote from the panel. Anita, you start first and survey the panelists. Who would proceed to deploy, and who would re-optimize the posterior again?
I mean,
So I think the 3D is really important. So, obviously with the longer arm clips, it's important to make sure that the orientation is just so, because you don't want to distort the anatomy. So
Yeah.
on
So
the
you can see on fluoro is pretty good. But, yeah.
Over talking.
Mm-hmm. Sorry. Go ahead.
So, on the 3D, I think it looks very nice. The residual MR looks minimal. Obviously, the other issue is in degenerative MR, we want to, restore the leaflet height back to normal. To Sushil's point, we want to make sure we've dealt with any prolapse. So the question is, are you happy with the position? Does it need to be moved slightly medial? I mean, looks like you've eliminated all the mitral regurgitation. The result is good. I'm not sure I would do anything different. So I would leave it, but maybe we'll start with Sushil and move across the panel and see what everybody thinks.
Yeah, no, I think it's very reasonable to leave. It's one of those things where, sometimes you open and say, I'm going to grab more, and then you sort of regret and say, I should have just left the first. So I think this is one of the challenges, and it's where the experience comes in, and it's where we're comfortable. I think it was a pretty straightforward grasp. I think I'd probably leave it, but if somebody said, let's open and go a little more posterior and grab and see if we can reduce that prolapse, I wouldn't disagree, because I think we've done that many times as well, just to see if we can get it's a very controlled, stable procedure, so you can sort of play with it and optimize it a bit if you want.
This much MR reduction, I think I would definitely leave it. The difference between surgery and MitraClip is the repeatability. You can always come back if there are some residual that worsens over time.
Yeah, I'd leave it as well. I think
Yes.
you've essentially eliminated the MR. Maybe there's a trace left. The V wave is markedly down. The orientation looks good. I think you've got most of the prolapse. So I'm pretty happy with that.
yep. Any other comments? Abstain. Brennan?
Renuka,
like
did
it.
Renuka talk already? I didn't hear her.
Yeah.
She's coming right here.
Oh, yeah, no. First of all, Gilbert, I think it's a great result. I also do all my MitraClips now in NPR because I just think it's so much more information that you get on trajectory and position. It seems like you have the right orientation, that you're not distorting anatomy. You have a great tissue bridge. I actually disagree slightly with the optimizing approach because I feel like we've done that before and then gone down a rabbit hole, and we're like half an hour later, like, well, we had just left the the first grasp. But I mean, I think it looks good. Steve, are you worried about anything?
No, I would just say that, at this point, the team has a conversation about release, and it includes everything you've already said, location, orientation, obvious MR reduction, but you've got a lot of other data. You've got the pulmonary veins. You have a quick look at the pulmonary veins. Did you resurrect the S wave? You were reversed. Is it upright? What's the LA pressure? And importantly, what's the mean diastolic gradient? In this case, you're probably fine, but sometimes...
Yeah, so let's go. Those are great points. So let's have Lucy tell us what the gradients are now with the across the valve and the pulmonary vein flow.
Sure.
I've done that. Well,
And then we'll go ahead and deploy. Dr. Kinney, what do you think?
no, I think I am a believer of the first grasp is the best grasp, and I think you've seen that here. More important is the reduction. You don't see any mitral regurgitation. So I agree with the panel with all the interesting points given, but having seen a reduction in mitral regurgitation, reduction in V waves, and if the insertion is good, we should just take this.
Yeah. How does the gradient look, Lucy?
Mean gradient was 4, and we did resurrect the S wave.
Did everyone see Lucy's echo images on the pulmonary vein flow?
I can reshow it.
Yeah, it looks fantastic.
Yeah.
And just to show the 3D MPR one more time with color, because we didn't really see that.
No problem.
So, just so. How come this looks a little bit further out now? What's going on?
Not on it.
Is it just the cut plane?
Let's just move on now.
No.
There.
Let's just show the color for a minute.
Color.
So,
Still good.
Okay.
okay, all right. So
Okay,
everyone
ready
agrees.
for
So
release, yes.
So we typically go to the LAO view. This is XTW. So we try to open check the final arm angle. So I put my hand on the lock so you don't accidentally get released, and we slowly open because there's been times that actually the clip you can actually see open up on the relaxation. So you can see it's not. So I'm going to tighten that again, and then we'll ask for the drips up. And then we'll have to do the lock line. So G5 still be nice, right? Anita, you want to talk about, some of you guys on the panel that play with G5. You want to talk about how this might be different?
I haven't actually seen G5. Maybe I'll defer to somebody else who's seen the G5 system.
I mean, I think it's addressing some of the issues. I mean, I think part of the challenges are stable release where what you get now, I mean, we've all had this frustrating moment. Sometimes you release and all of a sudden things change. And part of the fundamental thing is right now you're on a stick with the clip. And you're controlling the prolapsing segment. And I think especially in a Barlow's, and Renika or Anita and others, just weigh in, please, these Barlow's, and all of a sudden then there's a lot of excessive motion, and that's part of the challenge. But I mean, I think G5 is going to give us a little bit more control. There's more torqueability of rotation. When to orient the clip, there's less stored torque, better, ability to measure hemodynamics. I think just more usable device is sort of from my perception of it.
Yeah, I also watch clip deployment on NPR as well, because you can sometimes pick up these subtle changes even before they become clinically relevant. And so I'll actually watch it here and just see how it moves. I think Sushil brings up a good point there. You have it on a stick right now, and when you release it, there is oftentimes just a slight amount of movement.
3, 4, 5, 6, 7, 8. Okay, we're going to deploy the clip now. Okay, we're going to grippers up. So there we go. So there's always a bit more motion because it's primary MR, but looks pretty stable. Haven't changed, we can see.
Okay, come out.
Okay.
They can go to the other room. They're ready with the second
So what does everyone think? Happy?
Yeah, so one quick question for the panel, and this is where I
This is you.
struggle. This looks great. There's no MR. I wouldn't do anything different. But, the ones where you have a lot of motion, a lot of redundant tissue, this idea of a second clip for stabilizing. And this has some medial to lateral motion in the ventricular portion, which is, I'm not sure, that bothers me a bit, but the MR reduction is great, so I wouldn't do anything because you compromise gradients. But what do people think about this idea of stability?
I mean, I think it's a great point, and we see that a lot. And if we had valve area and the gradients were low, we might consider adding an XT beside it just to stabilize it. But there's no evidence to support that we need to do that. I think that's how we feel that motion over time may contribute to other dysfunction or other flail, adjacent to the clip, but we don't actually know that.
I mean, I think you weigh risks and benefits. Mean gradient is 4 already. You probably have enough mitral valve area.
Guys coming out.
It does look a little bit more mobile, but remember, that's a prolapsy posterior leaflet, so you would almost sort
Lucy,
of expect
guy
it.
is coming out. Okay, we'll just pull back the guy to
I
the
think
right
they're done.
atrium. And then we are done. So I think, thank you for excellent discussion about, clip selection, device selection, imaging, MPR. I think that we showed just what MPR can really cut down your procedural time with MTR now. You can see this is, obviously not a straightforward A2, P2 in the center, but rather more lateral. And despite that, we got, I think, very acceptable result in an 85-year-old. So thank you. And I think we're going to now turn our attention to the other case, and we're going to run across right now.
Yeah.
Great.
Any last comment?
We are ready.
Regina?
Very good. Yeah, they go.
Okay, thank you.
Thank you to the whole team. That was excellent.